Hi there, I'm Dr. Mohammed Balghith. I'm interventional cardiology from Saudi Arabia, Riyadh, and I would like to welcome my colleague from Kuwait, Dr. Abdullah Alenezi. My talk today will be about Onyx DAPT 1-month program, and we'll try to summarize the sub-analysis. We know that the one-month DAPT program by Onyx is one of the best data we have nowadays. There is a Onyx One global study, which was international multi-center, and there was the Onyx One clear analysis, which is mainly from the two countries, United States and Japan. When we talk about sub-analysis, here we're going to start with atrial fibrillation sub-analysis from the Onyx One clear study. And it was mainly those patients with atrial fibrillation, as we know, most of them, or the majority, they are on anticoagulation. Whenever we put stent, it's a big concern for us. And this study and this sub-study analyzed patients who had a history of atrial fibrillation and patient with no history of atrial fibrillation. They were included on the DAPT 1-month program, Onyx DAPT 1-month program. And the follow-up was for 1 year. And there was no major difference in the patient characteristic in both group, the AFib and non-AFib. Also, there was no difference in the lesion characteristics for those two groups. And the best graph we have is the graph which showed the result between atrial fibrillation and non-atrial fibrillation groups at the end of 12 months. And this showed the cardiac death and MI from the time of single antiplatelet therapy initiation. There was no significant difference between the two groups, and almost both of them, they have the same result. The second sub-analysis was for the PCI or complex PCI patients. The Onyx One clear primary analysis population for the complex high bleeding risk population divided those patients into two groups, the complex PCI and the non-complex PCI. And the definition for complex PCI, it met at least one characteristic, like 3 vessels treated with the PCI, or more than 3 lesions treated by PCI, or a total stent length more than 60 millimeter, bifurcation more than 2 stents implanted, use of any atherectomy device like rotablation, left main PCI, surgical bypass graft, or chronic total occlusion or CTO. There was no clinically significant or statistical significant difference between the two groups, either in the baseline characteristics or the lesion characteristic. But as we mentioned, the complex PCI, there was more multi-vessel, more moderate to severe calcification, more CTO, and more type B2 and C lesions. Patient in complex PCI group broadly reflect a complex criteria, which was characterized, as we mentioned, in more than 30% of those group by total stent length more than 60 millimeter and more than 3 lesions or surgical bypass graft stenting. And the main and important result here, there was no difference in the safety and efficacy observed in the complex PCI versus non-complex PCI group, in spite of increased lesion complexity. And actually, there was more MI and target lesion failure and cardiac death and MI in the complex PCI. The last sub-analysis is the acute coronary syndrome sub-analysis. And as we know, in this study, the 1-year follow-up on about 1,000 patients with a high bleeding risk ACS patient, divide those patients with ACS into 2 groups, patient who received Resolute Onyx DS versus patient who received BioFreedom DS. And in each group, about 500 patients and the follow-up was excellent, 99% versus 98%. There was the main and important result, there was a significantly higher device success with Resolute Onyx. And regarding the main and important results, Resolute Onyx was safe and effective in highly bleeding risk ACS patient on 1-month DAPT program. And there was more increase of MI numerically and also by statistical significance, p-value 0.02 in the patient who received biofreedom. I would like to hand you now to my colleague, Abdullah Alenezi from Kuwait. He is one of our colleagues as interventional cardiologist from Kuwait.
Thank you, Dr. Mohammed, for this excellent presentation. Hello, everyone. Today, I'll be talking about renal denervation, and more specifically with regards to the latest evidence from the global Simplicity registry. So this picture of the world map shows the prevalence of hypertension in the year of 2000 and the year of 2010. Countries shaded in light pink have a very low prevalence of hypertension, and the darker the pink, the higher the prevalence of hypertension. And we can see that first, there's a global burden of hypertension, and this global burden of hypertension is actually growing when you compare to the year 2010 to the year of 2000. So that's why hypertension continues to be the leading preventable cause for premature death worldwide. This is despite lifestyle changes and the multiple classes of pharmacological therapies. Renal sympathetic nerves are considered a therapeutic target to treat hypertension. And you can see from this anatomical dissection specimens that the renal artery, main trunk, and the branches are heavily innervated with the sympathetic nerves. And in theory, if you can target these nerves, you might have an effect on reducing peripheral vascular resistance and ultimately reduce systemic blood pressure. This is a study looking at the histological specimens and the effect on the renal sympathetic nerves following renal denervation. And we can see by day 7, there is evidence of necrosis. At 2 months, there's evidence of inflammation. And by 6 months, there's evidence of fibrosis of these sympathetic nerves, suggesting that likely this effect will be long-standing. Following the clinical trials that showed statistical benefit of renal denervation on the reduction of blood pressure, there is ongoing global Simplicity registry to look at the real-world data with regards to the effect of renal denervation outside of the clinical trial environment. And to date, we have around just short of 3,000 patients enrolled, and we have data up to 3 years. And what we found from these data, that the baseline characteristics of these patients, their average age is around 61, with a slightly higher representation of males of 57%. These patients have multiple comorbidities, including cardiac disease in 48%, which is around 50%, atrial fibrillation in 11.5%, high percentage of type 2 diabetes of 40%, and chronic kidney disease of 20%. And these patients are considered high risk. They have atherosclerotic cardiovascular risk score of 25%. Looking at their baseline blood pressure, the office blood pressure, systolic is around 175, and using the 24-hour ambulatory blood pressure, it's around 157. So they truly have elevated blood pressure, despite at least for 3 to 4 antihypertensive therapies. So if we look at the effect of renal denervation, the effect is actually evident at 6 months, but continues to be there for 3 years, suggesting that this effect on blood pressure, both the office blood pressure and the 24-hour, is maintained to 3 years. And this correlates with the histological findings that I showed you earlier, that actually the sympathetic nerves do develop fibrosis, suggesting the effect is not edema related, it's actually related to a fibrosis that develops in these nerves. And these effects on the blood pressure reduction was also sustained regardless of the number of antihypertensive medications. Here we can see on the left-hand side, the cohort of 3 medications, in the middle 4 medications, and on the right-hand side, 5 or more antihypertensives. And still we can see the effect of renal denervation in all these groups. At baseline, before any renal denervation is being performed, just the 21.6% of patients had their systolic blood pressure of less than 150, but by the 3 years following renal denervation, 55% of patients had their systolic less than 150, suggesting an effective therapy that is actually durable up to 3 years. And on the left-hand side, you can see that this did actually happen despite no increase of antihypertensive therapy, suggesting that the effect is actually the effect of renal denervation. And if we look at some safety parameters, the mortality in this cohort group throughout the 3 years was 5.5%. 2.8% of them was related to cardiovascular death. MI happened in 2.3%, stroke 4.7%, end-stage renal disease was 1.9%, which is low and reassuring, as well as the creatinine elevation more than 50% was 1.4%, with a very low new renal artery stenosis, more than 70% at 0.3%. So all of these events are not surprising in this high-risk cohort of patients, and specifically related to the procedure itself, the new renal artery stenosis is very low at 0.3%. If we look at our experience at the Chest Diseases Hospital, we did perform renal denervation in 13 patients. Obviously, it's a small number of patients, but our preliminary data suggests that we had 100% success with the procedure. We didn't have any immediate procedure complications. Actually, interestingly, we had, out of the 13 patients, we had 2 patients who had severe renal artery stenosis that was not previously appreciated. And we performed stenting in the same setting with very good results. With regards to the technical issues, the procedure actually is very easy to perform. However, one thing we learned that the procedure can be quite painful. So it's very important to be prepared to give patients pain medications before you start the ablation, because it can cause significant pain. We've created a hypertension clinic at our hospital to manage the referred patients to the clinic, and also to follow the patients following the procedure to make sure that these patients do benefit from the procedure, and that we are giving them a better control of their hypertension before we send them back to the referring physician. So in conclusion, I think I've shown you that hypertension continues to be a leading preventable cause for premature death worldwide, and this problem is actually a growing problem despite the multiple classes of antihypertensive therapies available. Renal denervation seems to be a very effective and durable therapeutic option, and it's an emerging therapeutic option in addition to lifestyle and pharmacological therapies. It's not meant to be a replacement, it's just meant to be an additional option to treat these patients that are largely undertreated. The Global Simplicity Registry showed clinically meaningful and statistically significant reduction in patients with resistant hypertension. This is from a real-world data outside of the clinical trial environment. Thank you for your attention, and I'll revert back to Dr. Mohammed Balghith to give his final remarks. Thank you.
Thank you, Dr. Abdullah, and I would like to summarize those sub-analyses. First one is atrial fibrillation group versus no atrial fibrillation. There was no significantly difference between the two groups. And the acute coronary syndrome patient, which was a good percentage in this study, there was also no significant difference between the two groups. The good news in those patients, the stent thrombosis was low in both groups, and also in the complex PCI sub-analysis versus no complex PCI, there was no statistical difference between the two groups, and the good news that both, even in the complex PCI, the stent thrombosis was low. And I think because of this good result, the FDA gave the Onyx the approval to be used in high risk bleeding patient and DAPT only for 1 month. And at the end of the session, I would like to thank my colleague, Dr. Abdullah Alenezi from Kuwait, and all the audience for the attending.